on to testicular cancer. Testicular cancer can affect men of any age. It is considered quite rare, but if a male is going to get testicular cancer, it will occur between the ages of 20 and 35. This age is special time in a male's life in that he is probably family planning, he's building a career, and most often in his sexual prime. Being diagnosed with testicular cancer is quite impactful on their life and identity. But there is great news. There is a 95% cure rate. The cancer can occur bilaterally and unilaterally. Most types of testicular cancer is germ cell cancer, testicular cancer, which is from the sperm-producing cells, and non-germ cells. Non-germ cell cancer is less prevalent and is from the Leydig cells that produce testosterone. Specifically speaking about germ cell, now if you have a germ cell tumor, you hope it is called a sonoma. This is usually localized tumor and metastasis is late and it responds very well to treatment. I'm going to repeat that again. Right here, sonoma. If you have germ cell testicular cancer, you hope that it is a sonoma, which is usually localized tumor. It metastasizes late, meaning it takes a long time for it to spread, and it responds well to treatment. Non-germ cell cancer, an example will be interstitial cell tumors, or it's known as androblastoma. These sometimes secrete estrogen and they can lead to gynecomastia. You probably remember this person right here. This is Lance Armstrong, and he is most notorious for winning many Tour de France titles, and he actually tested positive for testicular cancer. He was diagnosed at 25 years old with stage 3 testicular cancer. It had already spread to his lungs, abdomen, and brain. It seems a little bit more than stage 3, but I'm just reading the script. Interesting. So let's talk about some of the risk factors. Failure of a testicle to descend into the scrotum is about 50 times more common than men with normal anatomy. So an undescended testicle increases someone's risk for testicular cancer. They can do a procedure called an orchiopexy, which brings the testicle into normal position, and this definitely reduces the risk. Testicular tumors occur more commonly in a surgically descended testicle than in a naturally descended one. For anyone who's going to be a pediatric or a nursery nurse, this is a conversation to discuss with some parents in the event they need to be extra vigilant about assessing for testicular cancer or teaching their adult son to test for testicular cancer. So how is it going to present? Let me finish up with the risk factors. It is more prevalent in white males, and it usually affects just one testicle. And it can affect both, but it is rare. Common signs and symptoms are going to be painless, hard swelling or enlargement of the testicles. Patients are going to be complaining of a heaviness, as indicated by the weights, a heaviness and aching in the lower abdomen. They're also going to have testicular pain, possibly lymph node swelling, possibly bone pain, and, as well as abdominal mass. You may see a hydrocele, which is a collection of fluid in the scrotum. And depending upon the tumor type, we may see gynecomastia. Do ask the patient about sperm banking, as retroperitoneal lymph node dissection or chemotherapy may leave the person sterile from trauma to the sperm producing cells or to the nerves, which can cause retrograde ejaculations. A patient psychosocial assessment is something that should definitely not be ignored. They may feel embarrassed, so be sure to provide privacy and explain everything. Usually, the provider actually checks for lumps or masses to make the diagnosis. This isn't something a nurse typically does. Treatment in the cancer itself may lead to sexual dysfunction, so we must be in tune to a person's psychosocial health. Where a man before testicular cancer may see himself as this, afterward he may feel just less of a man. He may also express feelings that he can't perform, he can't reproduce, he is no longer sexually attractive, and that rejection is just imminent. So do make sure to assess their support systems. Do they have a partner, a friend, or family member, or a community group that understands them? The alpha-fetoprotein test and the beta-HCG are actually tests for pregnancy. However, we can actually use them to help us diagnose somebody with testicular cancer. Specifically, if somebody is positive for a beta-HCG, which is either a blood or a urine test for pregnancy, or if they are positive for a alpha-fetoprotein test, then we will make the diagnosis for both of these, if positive, that a patient has a semi-anoma. There's actually a good prognosis, as we mentioned earlier, for a patient who has a semi-anoma type of testicular cancer. An LDH test is a serum blood draw that we can do. It's formally known as lactate dehydrogenase. This is an enzyme involved in energy production, and it is found in almost all of the body's cells. Why is it useful? Well, that's a great question. A lot of times we use it to help detect a condition that is causing tissue damage, and the amount of tissue damage is directly correlated to how high the LDH is. I will like to mention that bacteria also produces LDH. So sometimes if you have a high LDH, you have to rule out that somebody has an active infection going on. But we'll draw these to help tell us if the testicular cancer is present. We can use it to monitor its progress and to help stage and determine prognosis. We will also grab testosterone levels on patients because these are increased if a non-germ cell tumor is present. Because remember, there is dysfunction of the Leydig cells, therefore they'll produce extra testosterone. Other diagnostic test that we can do is an ultrasound. This is pretty simple and easy to do. It will show us if excess fluid is on the testes or if a solid mass is present. This also helps let us know if the mass is benign or malignant. But I will say, a biopsy confirms the diagnosis. Ultrasound just assists in making the diagnosis. We can do a CT of the abdomen. This is looking for metastatic lesions. Likely chance that if the lesion is metastatic, it's going to go to the lungs, the liver, the viscera of the organs, bone, the iliac area, and the periaortic area and mediastinal lymph nodes. The periaortic area is really kind of where your belly button may be. If we wanted to know the levels of, or the degree of lymph nodes that are involved, you can do a lymphangiography. This is going to show the spread of the lymph nodes when we take some dye and we inject them into the lymph system. And we'll take a series of x-rays, such as fluoroscopy, to see where the dye is going and where it's not going, probably because of a tumor. MRI here will help us detect an enlarged lymph node and nodules in other organs. All of these can be used to diagnose testicular cancer and to monitor it. One of the interventions we should consider is protecting a man's ability to reproduce. That means we should protect the sperm. In fact, sperm banking is a very possible option, and we want to consider doing sperm banking if somebody has a low sperm count, specifically called oligospermia, or if they have the absence of living sperm. This is known as azoospermia. This is very common and may occur from the tumor, from surgery, or from radiation, or from chemotherapy. Pregnancy has been successful for sperm banked even up to 10 years, which is pretty crazy in my book that the sperm can stay viable for that long. But it can be reimbursed by insurance, the storage, the collection, and the insemination process. Do make sure to ask about religious or personal beliefs about sperm banks, because this can be controversial. For some men, to know that this option exists is very reassuring, and you may have higher chance of them being compliant. And do make sure sperm collection begins right before radiation treatment and chemotherapy, as quick as you can after the patient's diagnosis. The possibility of creating mutagenic sperm is possible if you were to do sperm collection after such treatments. Now, don't forget, there's always sperm donors and adoption. So let's move to surgical management. A patient does have the option for an orchiectomy, which means removal of the testicle. Surgery is the main treatment for such cancer, and oftentimes all it requires is unilateral orchiectomy. We're possibly going to use a minimally invasive technique. In this case, we are going to instill CO2 into their abdomen and then insert some scopes, kind of like what we do laparoscopically. If you remember, we are going to anticipate that the patient is going to have referred shoulder pain and chest pain afterwards. We tell them to walk it off. With the minimally invasive surgery, they're going to have minimal bleeding, recovery time is faster. If they want to, they can actually have a silicone prosthetic surgically implanted at the time of the removal of the affected testicle. I mean, they don't have to do it then, they can do it later if a seminoma is removed via a groin incision. This surgery of an orchiectomy does not lead to impaired sexuality or infertility if they just take one. If they do an open approach, they could do a radical retroperitoneal lymph node dissection if it appears that the cancer has spread. This is an extensive incision from stem to stern, and sterility will occur. I don't know if you are familiar with that phrase, stem to stern. Basically, that's fancy for a large abdominal incision. That's probably going from top to bottom. A paralytic ileus is likely with this procedure, also known as the radical retroperitoneal lymph node dissection. We're going to make sure to monitor vital signs, their pain, hydration, because all surgeries need fluid. And don't forget about the incentive spirometer. Post-op pneumonia is a real thing with any belly surgery. You're going to want to make sure they have their SCDs on, maybe some TED hose, because they're going to be hospitalized and sort of immobile for a few days. For metastatic disease, the primary treatment is chemotherapy, or you can use chemotherapy adjuvant as adjuvant therapy for the non-seminomas. If you do use the testicle shield, let me rephrase that. If we are going to send our patient for radiation therapy, they are going to need a testicle shield to reduce the scatter rays that may affect the healthy testicle. Somebody is probably going to have to do sperm counts, intermittent sperm counts. They are expected to be low, but they do return to their normal levels in about 2 years. And that's actually what this is right here. It's a testicle shield for the good testicle. There will not be a dressing on the scrotum for an open orchiectomy. The patient may wear a dry dressing to prevent rubbing from clothing, but generally there's nothing there. They will need a scrotal sling, it's evidence here, for a few days, scrotal support. The sutures do need to be removed as well in about a week, maybe up to 10 days. Definitely no lifting greater than 15 pounds. They need to avoid stairs or even driving for a few weeks because they cannot comfortably sit in a car, work the controls, wear a seatbelt, and look over their shoulder, or even make an emergency stop while they are recovering. Are you going to apply heat to the scrotum or ice? Hopefully the option you said was ice. So please put an ice pack to the scrotum. Teach them about the signs and symptoms of infection. If they had the minimally invasive surgery, they can resume work in 1 week. In fact, they can probably start taking showers 1 to 2 days after surgery. There will probably be some steri strips. These are little pieces of tape that are specifically made to fall off in 7 to 10 days, and they keep the incision closed. Make sure to leave those on there. And if the edges start peeling off, a patient can snip the steri strips. Don't pull them off. They have to fall off themselves. We need to encourage them to continue monthly testicular exams on the remaining testicle. And we're going to, in about 3 years' time, do follow-up tumor markers on them. And we're also going to do a CT scan. There's a great website called resolve.org. It can be a really good resource for patients recovering from testicular cancer.